Hello everyone, my name is Ariel Guerrero, a general practitioner currently completing my rural health year. I am starting this series of videos to assist medical students in understanding the clinical scenarios they may face once they become professionals. Let's begin. This is a case I encountered about 2 weeks ago. It's a 24-year-old male patient who came in with pain in his right leg. The key here is that he had fallen off his motorcycle 2 days prior at low speed, landing on his right side and impacting the asphalt. He had abrasions and superficial skin wounds on the right side on his right leg. He was able to walk and no major issues, and there wasn't significant blood loss, so he didn't seek medical attention. However, 24 hours before the consultations, he started experiencing fever, chills, and pain in the leg. On physical examination, there was poorly demarcated erythema, no signs of exudate, tenderness to palpation, increased skin sensitivity, and moderate edema. His vitals shows a fever of 38 degrees Celsius and a heart rate of 110 beats per minute. The first thing you need to think about and immediately suspect is cellulitis. With the poorly demarcated erythema, we already distinguish it from erysipelas, as both are common skin and soft tissue infections. Why do we suspect cellulitis here? Because it's accompanied by fever, tenderness, and a history of trauma. Let's remember that both erysipelas and cellulitis are more common in the lower limbs because they are more prone to trauma. When the skin barrier protecting us from infectious agents is broken, the Streptococcus and Staphylococcus bacteria commonly found on our skin take advantage and invade deeper tissues and causing infection. In this case, we must directly suspect cellulitis. Therefore, the presumptive diagnosis will be post-traumatic cellulitis of the right leg. What should I do as a rural doctor? 5 important points. 1. Appropriate antibiotic management. We'll discuss the options shortly. 2. Local management. This refers to control edema if present and cleaning the wounds. 3. Symptom control. Manage general discomfort and fever. 4. Following up and monitoring. This ensures the infection is resolving as expected. 5. Patient education. Teach the patient how to manage their condition. Antibiotic treatment must be empirical, targeting the most common infections agents which are gram-positive causes. The primary pathogen in both erysipelas and cellulitis is Streptococcus pyogenes. However, in cellulitis, it's often accompanied by Staphylococcus aureus. This is why in erysipelas, which has well demarcated borders, we can treat it directly with penicillins like amoxicillin, targeting only Streptococcus pyogenes. While in this patient's case, since it's cellulitis, we must cover both. Which medication do I choose? It depends on the severity, location, and clinical condition of the patient. We have several antibiotic options that can cover these pathogens, including beta-lactams like first and second generation cephalosporins, lycopeptides, vancomycin, macrolides, erythromycin, clarithromycin, azithromycin, lincosamides, clindamycin, oxacillinones, linezolid, fluoroquinolones, and tetracyclines. A first or second line regimen should be followed depending on the situation. And how to know that? You must evaluate if the patient requires coverage for methicillin-resistant Staphylococcus aureus MRSA. When should this coverage be required? When there are systemic signs of toxicity such as fever, greater 38 degrees Celsius, hypotension, tachycardia, prolonged cellulitis, and no MRSA infection, intravenous drug use, or a high risk of neutropenia. Examples of patients at high risk for neutropenia include oncology patients, those with autoimmune disease, those on long-term corticosteroids, or transplant recipients. In my patient, there were systemic signs of toxicity. He had a fever of 38 degrees Celsius and tachycardia of 110 bpm. Antibiotic treatment, regardless of the specific regimen, should be administered for a minimum of 5 days. First-line antibiotics commonly available for non-MRSA cellulitis include cephalexin and dicloxacillin, 500 mg every 6 hours for 5 days. However, in my patient's case, MRSA coverage was required. The first-line treatment for this scenario is clindamycin, 450 mg every 6 hours. Clindamycin was what I prescribed. But it's important to be aware of the risks of Clostridioides difficile infection with its use. Another good option, almost equivalent to clindamycin, is trimethoprim sulfamethoxazole, though it's not usually available in our pharmacies. Typically, health centers like ours stock clindamycin, dicloxacillin, and cephalexin. And in this case, clindamycin was the most appropriate option. What shouldn't be used? Cefuroxime, a second generation cephalosporin, as it has not been shown to be more effective than other options. Amoxicillin, clavulanate, or amoxicillin alone is not effective for cellulitis, so it might work for erysipelas. Azithromycin is usually reserved as a second line option for erysipelas. What else should I suspect? Erysipelas characterized by wild-to-market borders and caused mainly by Streptococcus pyogenes. First-line treatment includes penicillin, G-benzathine, amoxicillin, or cephalexin, all of which are available in most health centers. Macrolides and clindamycin are second-line options. Stasis dermatitis, more common in older adults with comorbidities. It presents with pruritus and atrophic skin changes but lacks fever and significant pain typical of cellulitis. Can NSAIDs be used? NSAIDs like ibuprofen, ketorolac, and diclofenac can be used in mild infections. However, in moderate to severe infections with systemic sinks, paracetamol is preferred. Why? Because NSAIDs may reduce the visible signs of necrotic and soft tissue infections by masking inflammation, making it harder to identify complications. For mild cellulitis without systemic symptoms, any NSAID or paracetamol can be used. However, for moderate to severe cases, paracetamol is recommended 500 every 6 hours for 5 to 7 days. This was part of the treatment I prescribed for my patient. Local management involved cleaning the abrasions with chlorhexidine and covering them with dressings. Note, if there is significant exudate, avoid covering the wound as it can promote anaerobic bacterial growth and worsen the condition. Another key point in local management is elevating the legs. This helps by improving the drainage of edema and inflammatory substances, facilitating antibiotic penetration into the affected tissue. Follow-up: patients should return in 72 hours or sooner if alarm signs arise, such as persistent fever, unrelieved pain, worsening redness, or pus formation. Most patients improve and don't return, but follow-up instructions should always be clear. Patient education: advise keeping the wound clean and dry, using sterile dressings, avoid scratching, and maintain good nutrition and hydration for proper wound healing. Finally, as this was a motorcycle accident, remind the patient to take greater care. This time it was just an infection, but it could have been worse, like a fracture or other serious injury. In conclusion, if you encountered a case of cellulitis in a rural setting, your first step is to determine the appropriate antibiotic. If it's erysipelas or cellulitis, you must evaluate whether MRSA coverage is needed. Local measures such as elevating the legs, wound care, and monitoring for alarm signs are also essential. That's all for now, and thank you.